السلام عليكم أعزائي الطلبة المرحلة الرابعة، وخاصة الجروب اللي ما صار عندنا فرصة نعطيهم محاضرة on face. Whatever it was supposed to be presented also online, on the stage and online, but you will receive this lecture in a form of recorded lecture. This lecture is the final and the third lecture of pituitary disease. We're going to talk about hypopituitarism. And it will be very easy to understand this lecture, especially on the basis of what was presented in the previous two lectures: anatomy, especially physiology of the pituitary diseases, classifications, and especially we have a detailed discussions about certain type of pituitary disease. So in this lecture, we're going to discuss the definitions of hypopituitarism, etiology of hypopituitarism, and the presentation of hypopituitarism. Importantly, how to diagnose and how to interpret the laboratory investigations in order to diagnose hypopituitarism, and finally, how to manage patients presented with hypopituitarism on the basis of on the hormone that was affected by hypopituitarism. So hypopituitarism is a deficiency of two or more hormones of the anterior pituitary glands, but also posterior pituitary gland included in these definitions, from disease that can affect the pituitary or hypothalamus. So the presence of two or more hormones affected give us a definition of hypopituitarism, while in the presence of all hormones of the pituitary gland affected will be called panhypopituitarism. And the presentation of hypopituitarism is dependent on the onsets of the deficiency of these hormones, and importantly the numbers and the severity of the hormones affected and their target organs, and the age of presentation of the patients also affect the presentation. For example, if a patient have hypopituitarism with the gonadotrophin is affected in this hypopituitarism at the age of presentation but below the puberty, the patient will have a presentation of delayed puberty, and also in the case of growth hormone deficiency, the patient will have short stature. While later on, when the presentation presented at a later age, the patient will not have short stature on the basis that the patient have reached his final height before the development of hypopituitarism. And also again, there will be no delayed puberty since the patient is already received a full puberty, but instead will have a manifestation of hypogonadism in both gender, whether in male and female. And also the underlying cause of hypopituitarism can have its own presentations. For example, if the hypopituitarism is a result of big pituitary tumor, this big pituitary tumor of course will have its own pressure effects, causing visual field defects like bitemporal hemianopia and headache. And so the underlying cause of hypopituitarism will have its own impact on the presentation of patients with hypopituitarism. Let's have a look to this patient. These investigations found in a 40-year-old man who presented with cold intolerance and fatigue. He had a history of motorcycle accident with head trauma 6 months ago. So from this presentations, a 40-year-old man, he's an adult patient having a cold intolerance and fatigue. These cold intolerance and fatigue is a vague symptoms, can be seen in many of chronic disease and in many types also of the endocrine disease. But cold intolerance is typical symptoms that usually seen in a patient with hypothyroidism. And again, the patient have history of 6 months ago motorcycle accident with head trauma. Head trauma is something, an important event that happened to the patient 6 months ago, and this head trauma may be responsible for this patient presentations. If I look to these laboratory investigations, you can see that the TSH is 5, is a little bit normal, but we have a low 3T4, so there is a deficiency of thyroid hormone while the TSH is normal. The cortisol is below normal while the ACTH in the low normal range, but still within normal. And we have here the luteinizing hormone within the normal range, while the testosterone is below normal. So for the first, you can look here to these end organ hormones. The free thyroxine hormone is low, and the cortisol is low, and the testosterone is low. So we have hypothyroidism, and we have hyperadrenalism, and we have low testosterone levels, suggesting the presence of hypogonadism. But what is the cause or underlying cause of these deficiencies, hypoadrenalism and the hypothyroidism and hypogonadism? We know that the types of pituitary deficiencies could be either primary pituitary disease when the target hormone is affected, and secondary when it is as the result of hypopituitarism. So in the concept of primary disorders, for example, in patients have a primary hypothyroidism, the expected TSH will be very high in the setting of such a very low level of FT4. And the same is true for patients with hyperadrenalism. In setting of such a low cortisol level, you would expect to have a high ACTH level, like in patients with Addison disease. And the same applied for the hypotestosterone level and hypogonadism. If the testosterone is low, the expected LH and FSH should be very high in these conditions. Like example, patient or having primary testicular failure, like Klinefelter syndrome, or whatever the underlying disease. So, since these TSH and the ACTH and LH hormone within the normal range, these hormones from the anterior pituitary gland fail to increase as a response of the loss of the negative feedback effects from these target hormones. A finding suggesting that these deficiencies of FT4 and cortisol and testosterone level, it's not due to primary organ failure, it's from secondary failure at the level of pituitary and the level of hypothalamus. So this patient having a hypopituitarism with the symptoms of hypothyroidism that's secondary as a result of previous head trauma from motorcycle accidents. So the question here, which of the following should be started first in the treatment of these patients? All these kinds of therapies are hormonal replacement therapies can be used in the management of hypopituitarism depending on the hormone that's affected. So we can give thyroxine, hydrocortisone, desmopressin, testosterone therapy, and growth hormone. But the question here, which is the most important hormone that should be started and should be started first to this patient in sake of saving the life of these patients? So let's keep the answer of this question to the end of the presentation. The patient giving a full replacement therapy with hydrocortisone 20 mg in divided doses, L-thyroxine 100 and testosterone cypionate 50 mg IM every 2 weeks. And after 2 days of the replacement therapy, the patient was doing well, but he developed an excessive urination and thirst. So what could be causing this excessive urination and thirst in such a patient who was previously having no polyuria or excessive thirst, or polyuria or polydipsia? Is it due to untreated growth hormone deficiency, or it is an effect of the replacement therapy with hydrocortisone, or does the patient develop diabetes and cause polyuria and polydipsia? Is it an effect of testosterone treatment or the effect of thyroxine treatment? And again, we're gonna leave the answer of these questions to the end of presentation. What are the etiologies of the hypothyroidism? Structural disorders of the pituitary are the commonest cause of hypothyroidism. We discussed the macroadenoma should be large, macroadenoma to cause hypothyroidism, carcinoma exceptionally rare, supracellular masses like craniopharyngioma, meningioma, secondary tumors like leukemia, lymphoma, chordoma, germinoma, and embryologic defect, the Rathke's cleft cyst that cause a cystic lesion inside the pituitary can also result sometimes, rarely, to cause hypopituitarism, especially when it is large enough. Apoplexy, pituitary hemorrhage, usually seen in the patients with the use of anticoagulant therapy, and this put the patient at risk of pituitary hemorrhage like any site of the body that can develop hemorrhage as a side effect of these anticoagulant. Inflammatory or infiltrative disease that can cause inflammation, diffuse inflammation of pituitary gland or infiltrations, like autoimmune lymphocytic hepatitis that can be seen usually in female in the postpartum period, sarcoidosis, iron deposition in the pituitary and hemochromatosis, histiocytosis X, and sometimes infection that can happen to the pituitary like tuberculosis, mycosis, syphilis, also can cause hypopituitarism. Congenital deficiencies of GnRH Kallmann syndrome can cause secondary hypogonadism from the hypothalamic disease with a GnRH deficiency called Kallmann syndrome, a syndrome that can characterized by not hypogonadism, by delayed puberty and later on hypogonadism. And 50% of patients, or even sometimes less, have a defective sense of the smell in the form of hyposmia or anosmia. Functional, like patient with a chronic systemic illness, especially severe enough, that can cause weight loss, anorexia, excessive exercise, like competitive athlete with such a very low body mass index. These can cause functional hypopituitarism from hypothalamic source. And others like head injury, like our patient we discussed, surgery or radiosurgery, also from reasons that can cause hypothyroidism as a complications of this treatment. Empty cellular syndrome, whether it is primary or secondary. Secondary is usually seen when there is previous history of pituitary tumors or surgery or radiations, while primary intercellular when the underlying cause is unknown, but there is a report of association of such a primary intercellular with the primary intercellular with a patient with a chronic headache and benign intracranial hypertensions. Other conditions like postpartum necrosis Sheehan syndrome. Fortunately, this syndrome rarely to be seen nowadays. During pregnancy, the pituitary glands usually increase in size to double or even sometimes higher, and this also associated with an increase in the blood supply of the pituitary glands. This is a physiological finding can be seen in a pregnant lady. And so at the time of labor, if a patient develop a severe postpartum hemorrhage that can result in a severe shock state, and this of course will affect the blood supply to such hyperatrophied pituitary gland that require a higher blood supply, resulting in necrosis. And this necrosis of pituitary can affect nearly all of the elements of the anterior pituitary hormone secretions. So the patient presented later on in the postpartum period with failure of lactations and amenorrhea. Besides that, there are many drugs like opioids can cause also hypopituitarism by its effect on the gonadotrophins, by its effect on gonadotrophins and on ACTH, and this usually happen at the level of the hypothalamus, at the level of corticotrophin releasing hormone and the gonadotrophin releasing hormones. So the physical findings is dependent on the cause and the presentations and the target hormone affected. So the presentation could be due to mass effect as we discussed in the previous lectures in the form of headache, visual disturbances, CSF rhinuria, hyperprolactinemia as a disconnection phenomena. ACTH deficiency is the most important one and feature of hypopituitarism. Like any patient with adrenal insufficiency, like patient with primary adrenal insufficiency in the form of Addison disease, secondary adrenal insufficiency can patient have fatigue that progress to weakness, anorexia, and the weight loss, poor intake, and in more severe conditions there will be abdominal pain, nausea, and vomiting, failure to thrive in children, low sodium level. Hypernatremia usually seen only in primary adrenal insufficiency, not seen here in hypopituitarism. And if the condition is out of onset, rapid onset, or abrupt failure of the anterior pituitary gland, it will be associated with hypotension and shock state, while hypotension is not seen frequently in ACTH deficiency, instead seen more in primary adrenal insufficiency, because the patient with a primary adrenal insufficiency will have deficiency of cortisol and also with aldosterone. TSH deficiency will cause symptoms of hypothyroidism, form of fatigue, weakness, weight gain, cold intolerance, anemia, constipations. Patients have a bradycardia, dry skin, other symptoms of hypothyroidism. I will be discussed in more details in the lectures of thyroid disease, and include also leg edema, and this leg edema is usually characterized by being non-pitting leg edema, changing in the quality of voice to have a voice with less quality, resulting in hoarseness of voice beside hairless, can be seen also in patients with other primary or secondary hypothyroidism. Gonadotropin deficiency: if the onset is before puberty, the patient will have delayed puberty and primary amenorrhea in female and delayed puberty in female, while if the presentation post-pubertal, patient have hypogonadism that's characterized by low libido, erectile dysfunction, gynecomastia in male, and also infertility in both gender, male and female, while female will have amenorrhea, hot flashes from estrogen deficiency. Vaginal dryness can result in dyspareunia and increased tendency for local genital infections. And beside, there will be low bone mineral density, in decreased muscle mass, and anemia. And this is hypogonadotrophic hypogonadism, to be differentiated from hypergonadotrophic hypogonadism, can have similar presentations, but the difference here, the FSH and LH will be very, very high in cases of hypergonadotrophic hypogonadism. Instead here, the FSH and LH will be either normal or low. And growth hormone deficiency. Growth hormone deficiency will have its main element of presentation of short stature, growth retardation, failure to thrive, may be seen in children, because growth hormone during childhood is of real importance to promote linear height of those children. So the child will have short stature, beside easy fatigability. There is a risk of hyperglycemia, but it's not seen frequently as hyperglycemia as a manifestation of growth hormone deficiency. But if the presentation develop later on post-pubertal after achievement of the final height, the growth hormone deficiency will have its own effect on reducing the muscle mass and increase fat mass, leading to obesity, to low bone mineral density, and also increase risk of cardiovascular disease in form of increased inflammatory cardiovascular markers, increase LDL cholesterol. Prolactin deficiency is rarely to be seen as a manifestation of hypopituitarism, and instead in many of the causes of hypopituitarism, like a presence of macroadenoma, there will be hyperprolactinemia as a disconnection phenomenon. It's called disconnection hyperprolactinemia, but can be seen when there is diffuse extensive damage of the pituitary gland. At this condition, the prolactin also be affected, and this seen in Sheehan syndrome. ADH deficiency, of course, we have a detailed discussion in the previous lecture. ADH deficiency will cause cranial diabetes insipidus. So what is the typical sequence of hormonal disruption in patients with hypopituitarism? The first hormone that will be affected, and which is the most sensitive hormone to be affected, is the growth hormone, and this followed by FSH and LH. And finally, the least hormone to be affected is the ACTH, and finally the TSH. So this sequence is not 100% to be seen in any patient with hypopituitarism, but in patients with the structural pituitary damage in the presence of pituitary tumors, the growth hormone is the first to be affected. We have a discussion about this slide in the previous lectures, and we're gonna give a presentation. I'm going to give another talk about this slide, which is very important. You can see here is the pituitary gland, and here is the hormone secreted from the pituitary glands. So when there is hypopituitarism, these hormones, two or more of these hormones, will be affected. So when these hormones are deficient, of course, there will be failure of the function of the other target organs, result in deficiency of these hormones, and so there will be the manifestation of hypopituitarism. But when there is a disease affecting these primary endocrine organs, instead, beside the associated decrease in these hormones, there will be loss of the feedback that will result in a high level of these pituitary hormones. because the pituitary is not affected when there is a primary organ failure here. That's why we can find a high TSH in patient with primary hypothyroidism. We're going to have a high ACTH level in patient with Addison disease. We're going to have a high LH and FSH level in patients with primary ovarian insufficiency, in patient with Klinefelter syndrome. But if the failure is due to pituitary disease and hypothyroidism, you will have a low pituitary hormones or normal pituitary hormones with low target organs hormones. So the investigation, patient with hypopituitarism can be diagnosed by the first step, by the finding of a normal TSH, ACTH, LH, FSH, or low. So they are either normal or low, or what's called inappropriately low, because it should be high in the presence of a low-end organ hormones like 54, cortisol, estradiol, and testosterone. There are other investigations that can be used in the diagnosis of hypothyroidism, like insulin tolerance test, a glucagon stimulation test for growth hormone that can be usually done in patient during childhood period to decide whether to give patient growth hormone therapy or not. Insulin tolerance test nowadays infrequently used, even it is the gold standard diagnostic test, the gold standard dynamic test for diagnosis of hypothyroidism and growth hormone deficiency, but it's difficult to be carried out because of the hypoglycemic risk, especially contraindicated in the presence of cardiovascular disease, epilepsy, and severe adrenal insufficiency. And also we can check for prolactin for disconnection hyperprolactinemia. We can check the urine osmolarity and serum sodium to diagnose the presence of cranial diabetes insipidus, or we can do a water deprivation test, and also do not forget the visual field testing in case of the presence of large pituitary tumors. So to summarize again, which is of real important, so ACTH deficiency will be diagnosed by low cortisol and normal or low ACTH, and sometimes you may need to do an ACTH stimulation test. The TSH deficiency diagnosed by a presence of low free T4 and low or normal TSH, and the FSH LH deficiency diagnosed by low testosterone in male and low estradiol in female together with low or normal FSH. For the presence of a growth hormone deficiency, we can rely on insulin-like growth factor 1 as a screening test for the presence of growth hormone deficiency, which should be below the reference range for the age and gender specific range for the patient we have to diagnose the presence of growth hormone deficiency. And this test is a screening test, should be followed by glucagon stimulation test for growth hormone. And in this test, the growth hormone, if failed to increase more than 10 nanogram per ml, there will be a diagnosis of presence of growth hormone deficiency. While insulin tolerance tests rarely to be done, as I said, because of the associated side effect like hyperglycemia, and it's absolutely contraindicated in patients with a seizure or ischemic heart disease or severe hyperadrenalism. Finally, ADH deficiency can be diagnosed by doing a desmopressin, by doing a water deprivation test and checking the response to urine osmolarity by desmopressin to confirm the presence of renal diabetes insipidus. After doing the laboratory test, the next step, any patient with hypopituitarism and an MRI imaging of the pituitary is needed to know the underlying cause of hypopituitarism. So you can see here this MRI image. This is an example of abnormal pituitary MRI. And we can see here the sella turcica, and this is a very slit-like small pituitary glands. This is typical feature of empty sella. And we can see here this shadow is sagging the optic chiasm. Findings suggested that this patient can have a previously a large pituitary tumor that just reduced in size by treatment or by autoinfarction, resulting in empty sella. So this is typical empty sella, and this patient is a real patient, have hypothyroidism with a history of chronic headache that is diagnosed by CSF pressure as having benign intracranial hypertension as a cause of empty sella and hypothyroidism. We will have a detailed talk about the benign intracranial hypertension hopefully in the next year in the lectures of neurology. Another example here, this patient, unfortunately, this patient passed away 2 years ago, having hypopituitarism as such a very big and large pituitary tumors. All this presently pituitary tumors causing extensive damage of the optic chiasm, pressure on the optic chiasm. You can see the chiasm here, and the pituitary. We cannot see and detect where is the normal pituitary tissue. The cavernous sinus cannot be seen, totally invaded. So this patient have hypopituitarism as a complication of this such a large pituitary tumors, and by investigation prolactin is 3000. So this very high level of prolactin is not a disconnection hyperprolactemia, suggesting that this tumor is a prolactin secreting pituitary adenoma. This is a large, giant, big pituitary adenoma. But this patient died because of other complications. Patient have an advanced type 2 diabetes on insulin, chronic kidney disease, and ischemic heart disease, who died from ischemic heart disease. Another live example from our patients that we used to be seen in clinical practice. The treatment is to treat the underlying cause and, importantly, the hormonal replacement therapy. So the most important and the first important hormone to be replaced in a patient with hypopituitarism is the replacement of the adrenal axis. So in case of ACTH deficiency, we will not give ACTH. There is no role for giving ACTH as a treatment of adrenal deficiency. Instead, we treat with either hydrocortisone or prednisolone in a dose of 15 to 25 divided, or prednisolone 5 to 7.5, 7.5, not 75, 7.5 milligram in the morning or sometimes divided. For hypogonadism, we're gonna replace with testosterone therapy for men, and for women we will give a continuous conjugated estrogen therapy in a dose of 0.3 to 1.25. In addition, we have to give the patient cyclical progesterone, like for example hemidroxyprogesterone, from day 15 to 25 to induce normal menstrual cycle. Even this is not normal menstrual cycle, because the normal menstrual cycle is a cycle that happened by the presence of intact hypothalamic pituitary gonadal axis. But in this condition, this not cycle is just a breakthrough, or this is just a withdrawal bleeding from hormonal replacement therapy. But why need to give progesterone for patients and continuous estrogen therapy? Because if the female on continuous use of estrogen therapy without bleeding, this will result hyperplasia and increased risk of endometrial hyperplasia and final and later on endometrial cancer. TSH can be treated by giving thyroxine therapy, the same treatment for primary hypothyroidism and hypopituitarism, and a growth hormone therapy is indicated for children, is universally indicated in order to improve the final height of those kids, while later on in the adult age there was a controversy about the beneficial effect of use of growth hormone replacement therapy in adults, and this is true for many reasons, because the aim of giving growth hormone therapy later on not for increasing the final height for patients with growth hormone deficiency during the adult age, instead to improve the fat mass and reduce the fat mass and improve the muscle mass. And this is not 100% a beneficial effect of growth hormone therapy. And again, the selection of a treatment should be on the base of the cost of benefit of the use of this treatment. Since the growth hormone therapy, the patient have to pay for it from their pockets, and it's a really expensive treatment, so we have to balance the benefit and the cost of the treatment before gonna prescribe this medicine for any patient with hypopituitarism. And for ADH deficiency, we have to give the desmopressin, as we discussed in the previous lecture of cranial diabetes insipidus. For any patient with hypopituitarism or patient with adrenal insufficiency, since the adrenal disease, when it is deficient, really hazardous and can lead to considerable morbidity and importantly mortality, especially when there is failure of effective replacement therapy and during stressful conditions. So if a patient diagnosed with hypopituitarism should carry this what's called the important medical card info. Usually we give the patient written in both languages, in Arabic and English, that give, as you can see here, details description of the disease and diagnosis, an important manifestation of severe condition, like in the event of severe illness, coma, trauma, vomiting, diarrhea. And also, we gave the prescription of the emergency treatment that should be given to the patient without delay in the presence of these conditions: hydrocortisone 100 milligram and IV saline. Because this card can save the life of patients, special patient when patient is presented to the emergency department in a coma state and no one knows what is the underlying diagnosis of hypopituitarism or other insufficiency, and simple finding and reading of such a medical important card info showing the important treatment that should be given to this patient in an emergency situation can save the life of the patient. And even if the patient collapses in an area that is far away from reaching the medical facility, if a patient have even a little experience with the use of medicines, can read such a card in Arabic word and can decide to give the patient hydrocortisone even in a subcut way, can save the life of patient with acute adrenal crisis. Pearls and considerations: all patients having a head trauma, especially when it is severe, should undergo assessment of anterior pituitary functions, and this should be done during the acute phase for a transient hypopituitarism and later on for 6 months in case of development of permanent hypopituitarism, just like our patient we discussed in the first of these presentations. Growth hormone, the most sensitive hormone that's affected and really vulnerable to effect of radiotherapy, surgery, tumors, trauma, and especially this is true for children. Thyroxine replacement therapy, importantly here, can increase the rate of cortisol metabolism and so can lead to adrenal crisis. That is why glucocorticoid should be replaced first in patients with hypopituitarism. So, as an answer to the first questions, which hormone should be replaced first? We should start with hydrocortisone, or at least we should start with hydrocortisone and thyroxine therapy at the same time. Otherwise, if we started the patient with thyroxine therapy, this thyroxine therapy will increase the metabolism, the body metabolism, or at least normalize to the already reduced rate of metabolism from hypothyroidism. So increasing the rate of metabolism, including also increase the catabolism of already deficient cortisol level. So it will precipitate acute adrenal crisis and can result in increased mortality of the patient without effective replacement therapy with hydrocortisone or prednisone. All patients receiving glucocorticoid, whether primary or secondary adrenal insufficiency, should wear a proper identifications stating that the patient having a diagnosis of hypopit or hyperadrenalism, and they are on replacement therapy, and the emergency treatment that need to be given in the cases of stressful conditions, just like the medical card info that I showed you. Stress doses, a higher doses may be needed to be given in the emergency situations and even can be given electively, like for example patient with hypopituitarism presented to the surgery, whether surgery that contain a moderate stress surgery or a severe stress surgery. The patient should not be kept only on the replacement therapy. Instead, we have to give a higher dose of steroid, for example 50 or 100 milligram hydrocortisone that used to be given at the time of induction therapy, and this also a clue for patient who presents in a severe medical illness like during septicemia or acute myocardial infarctions. And finally, why our patients in the presentation develop polyuria and polydipsia after starting replacement therapy. Many times patients with diabetes insipidus before replacement therapy does not have the full-blown manifestation of diabetes insipidus in form of polyuria and polydipsia, because in the state of cortisol deficiency, the ADH even in a small amount can have the job done without polyuria and polydipsia, because the cortisol have an inhibitory effect on the ADH level. So after replacement therapy, when there is a normalization of the overall state of hyperadrenalism and hypercortisolism, this increase in the cortisol level will inhibit the already reduced amount of ADH in a way that results in unmasking of the manifestation of diabetes insipidus, resulting in polyuria epilepsy. So, what was causing the new presentation of polyuria polydipsia to these patients after 2 days of replacement therapy is really the hydrocortisone therapy. And in order to improve the patient complaint, we have to not stop hydrocortisone therapy. Instead, we have to start him with desmopressin replacement therapy. So let's end this presentation with this question. A 40-year-old man is being evaluated for severe ulcerations found with endoscopy in the stomach and duodenum and esophagus. So the patients have extensive severe ulcerations. I know that from the lectures of a gastroenterology about the causes of the peptic ulcer, and the commonest cause is H. pylori. But from these many causes, none of them have the ability to cause severe extensive ulceration that can extend to the beyond the stomach and duodenum to reach to the esophagus. Findings suggest that there is an underlying severe conditions or a disease that can result in a higher rate of development of these ulcerations. 6 years ago, the patient had a history of acromegaly that was treated with surgery and radiosurgery, and the patient since that time in remission state. And here is the laboratory investigations. The growth hormone is 1 nanogram per ml within the reference range. He has a normal adrenal axis with a normal cortisol ACTH. All pituitary function tests is normal here in these patients. The parathyroid level, which is hormone secreted from the parathyroid gland responsible for controlling the calcium level, is high, together with a high calcium level, while sodium and potassium is normal. So the patient have hypercalcemia and have a high PTH level. So these two findings suggesting the presence of primary hyperparathyroidism. So we have a patient who have a previous history of acromegaly, previous pituitary adenoma, and have now asymptomatic primary hyperparathyroidism and having an extensive ulceration in the GIT and a CT scan finding in the abdomen showing the presence of 2.3 centimeter mass in the head of the pancreas. So what is best explain patient condition? All these choices from 1 to 5 represent a different endocrine syndromes that characterize the presence of multiple endocrine diseases, like multiple endocrine neoplasia type 1, MEN2, autoimmune polyendocrine syndrome type 1 and 2, and finally von Hippel-Lindau syndrome. So what could be responsible for patient presentations? For MEN2, in MEN2 patients usually have primary hyperparathyroidism from parathyroid gland hyperplasia, and also together with the presence of another endocrine tumors, including pheochromocytoma and medullary fat cancer. So this choice will not explain the patient conditions. The polyendocrine syndrome, these two syndromes, type 1 and type 2, these two syndromes characterize the presence of multiple endocrine failures and not tumors, characterized by presence a combination of type 1 diabetes, Addison disease, Graves' disease, Hashimoto hypothyroidism, primary hyperparathyroidism, beside other autoimmune diseases, not even an endocrine failure. Von Hippel-Lindau syndrome characterized by the presence of bilateral pheochromocytoma, renal cell carcinoma, and also by the presence of a cerebellar hemangioblastoma. The best thing that can explain patient condition is MEN2-1, because this syndrome, which is an autosomal dominant condition that's characterized by the presence of primary hyperparathyroidism with pancreatic neuroendocrine tumors of any type, whether gastrinoma, insulinoma, and the presence of pituitary tumors, pituitary adenoma, and any type of pituitary tumor, whether prolactinoma or acromegaly. Our patient have acromegaly first, and have a primary hyperparathyroidism, and have a tumor in the head of the pancreas that could explain the endoscopic finding by extensive ulceration, suggesting that this tumor possibly is a gastrinoma that excretes a large amount of gastrin. And you know that gastrin can stimulate the stomach to secrete large amount of acid, resulting in reducing the pH of the stomach to a very high degree, resulting in extensive ulceration that can reach from esophagus down even to the jejunum, not only to the duodenum. So the answer of this question is multiple endocrine neoplasia type 1. So this is the end of presentation وشكرا جزيلا لكم.